Well, so transplant has historically been one of the cornerstones of ALL therapy, particularly for patients with relapsed refractory ALL. And I would say that's with standard chemotherapy. And really it's more these novel agents that we have. So novel monoclonal antibodies, Inotuzumab and Blinatumomab, as well as CAR T cells that are diminishing and I think in the future may eliminate the role of transplant in ALL. So we and others have done a lot of investigation with these drugs, in incorporating them into the frontline setting. And I think that what we're seeing there is that when we incorporate Blinatumomab, Inotuzumab in combination, along with some chemotherapy for patients with ALL, we get much higher rates of MRD negativity, which we know correlates with better outcomes. And I think with incorporating these agents, we can overcome some historically poor risk baseline features that we historically would send patients to transplant for. We're seeing this most clearly in the realm of Philadelphia chromosome positive ALL. So with now chemotherapy-free approaches, for example, Blinatumomab plus a TKI, either Dasatinib or what we've been doing at MD Anderson is Blinatumomab plus Ponatinib, we see very high rates of molecular response, so high rates of MRD negativity. So far to date with that regimen, we've seen no relapses, and we've sent essentially no one patient went to transplant. All the others have not been transplanted. So what we see is when we use these more effective drugs, getting actually away from standard chemotherapy, we can hopefully eliminate the need not only of chemotherapy, but the need for transplant for our patients. And so we're hoping to do that even more in the Philadelphia chromosome negative B-cell ALL. I will say we still struggle with T-cell ALL, but hopefully we'll have better drugs for that disease as well soon. And hopefully we can reduce the need for transplant for those patients as well.